graduate of Harvard University, and his mentor was a very close friend of mine from Harvard University in Forsyth. So he's a diplomat of the International Academy of Dental Implants and Dental Practice, Limited Implant Surgery and Orthodontics. You may know of Sam's extensive work, especially in Ukraine, for the past couple of days, because they've been actually treating day and night army personnel and a lot of soldiers. And so we're grateful for not only for his excellent scientific background, but also for a lot of the public health services that he's giving. So Sam is going to give us a talk about several critical points about how to learn about the regeneration and dentistry. Thank you, Sam.
Thank you. Thank you very much. It's my honor to be here in Ukraine for the third time. I come from San Diego, California, and I practice in New York, Boston, and San Diego. We have an educational facility called International Academy of Dental Implants in San Diego, and we train many dentists around the world. But our mission is to help underserved communities. We've been to China, Dominican Republic, Mexico, many countries to help them regain their smile, and that is our main mission. At the same time, to advance education and research. My journey in Ukraine began with Myron. We came here last year to treat many soldiers. I consider them to be heroes. This gentleman, as you can see, he lost his leg for his own country, and he's a volunteer. And for me, as a doctor, to treat such a hero was a blessing, and I would like to give a special thanks to the soldiers and the anesthesiologists, nurses, and the surgeons in Ukraine who volunteer to make this happen. And we are happy to be here back after 1 year with a group of 14 doctors from United States, France, UK, Canada. Now, we're doctors. We treat patients, and we have huge responsibility. Because if we make a mistake, our patients will suffer. This patient, unfortunately, had a failed sinus, and patient suffered. When patient was referred to me, she couldn't drink. Every time she tried to drink, it would come out from the nose, and her quality of life diminished because of our failure. So how can we rescue such disaster? As a clinician, I always want to try minimally invasive approach. That way, I don't do any damage to our patient. So I let this wound heal, and best way to fix oral communication is not buccal fat pad, it's not rotated pedicle graft. It's actually to use obturator for a long time to prevent communication between antral and oral cavity. So after the soft tissue healed, it took about 2 years for the soft tissue to heal, we attempted to retry sinus lift. But because she had a dental trauma, she said, I'm very scared, Dr. Lee. Do you think this will work? Can you utilize minimally invasive approach when I redo the sinus case? So I believe in minimally invasive approach. Minimal incision is the best for our patients. In fact, if I want to undergo oral surgery, I want to choose minimally invasive approach for myself. So I made split thickness flap because I knew there was no bone under the implant site. After making split thickness flap, we elevated the flap and we folded the split thickness tissue into the sinus to be able to lift the sinus membrane. So after we push the split thickness flap into the sinus with very minimal flap, we're not doing lateral approach. Everything is done through crestal approach. Why? Because when we make incision, within keratinized tissue, there is virtually no pain. But when you extend your flap beyond mucogingival junction, then patients will have lots of pain and swelling. So as a clinician, I try to minimize the incision within mucogingival junction, and I will utilize the biomaterial to augment the site. And I like to use metronidazole in this case, just to make sure that we don't get reinfection into the sinus area. And gently, we will push the bone into the sinus. Remember, this patient had no bone. Patient had 0 millimeter of bone. Can we place implant at the same time? Well, the patients prefer to do only one surgery because of previous dental trauma. So we will try to place implant at the same time. But how can this be possible when there's no bone at the site? Well, if we know the osteotomy size, by undersizing the osteotomy of 1 millimeter, by choosing the right diameter, and by choosing the right shape of the fixture, we're able to place the implant and get enough stabilization so that we can have guarantee that we don't push our implant into the sinus during the healing. So as you can see, we're placing a 4.5 by 11.5 millimeter fixture, and even though we had 0 millimeter of initial bone height, we were able to achieve 50 newtons per centimeter. Why is this possible? In fact, this is much easier compared to when you have 10 millimeter bone. When you have 10 millimeter bone in maxilla, you only have 1 cortical bone and rest is medullary bone. However, when you have very thin bone, now we have 2 cortical bone and it's easier to achieve better initial stability. So as you can see, after the surgery, we were able to atraumatically lift the sinus without making huge incision, without making huge lateral window, and patient was very happy. But what's more interesting is, not only did a sinus lift, but we also did lateral augmentation. As Dr. Kroki mentioned, best membrane is actually periosteal tissue. I do not use membrane in my practice unless I have to. In this case, I didn't use any membrane to do this buccal graft. And 6 months later, you can see that we were able to maintain this bone because we had a very good periosteum. In addition, you can see the disintegration of old sinus floor, and we get a new sinus floor formation, new cortical bone formation. That's an indication that our graft has completely turned over to the native bone. Another case, this patient also received an implant. However, the implant went into the sinus. This is why we have huge responsibility. We have to know our limits. If we go outside the limits, our patients will suffer. Poor lady, she developed sinusitis after the implant went into the sinus, and she was referred to my clinic to remove not only 1, but 2 implants from the sinus. As a clinician, once again, we have to think, what is the best approach to rescue this case? I want to make as minimal incision as possible, and I want to make minimal trauma to the existing bone. As you can see, this is probably the previous defect. When you're making incision, rule number 1 that you have to remember is not to make incision where there's no bone. Always, you must make incision where you have bone. Otherwise, when you suture, that tissue will necrose. So in this case, instead of making traditional crestal incision, we will make palatal incision so that our incision line is on the bone for best blood supply. So we made palatal incision, and for me, making long vertical incision is very traumatic for the patient. In fact, mucosal tissue will extend. There's no reason to make long vertical incision. With only 2 or 3 millimeters of vertical incision beyond mucogingival junction, we can minimize swelling and pain for our patients. Yet, mucosal tissue will stretch, and you will have great access to your lateral window. In this case, I chose to do lateral window because implant was too large. I thought it would be very difficult for me to remove an implant from crestal approach. But I want to minimize the surgical time to our patients, so we will utilize the latest technology in sinuslift. This sinus burr will be able to grind the sinus bone, yet not perforate the membrane. Why? Because there's a hydraulic pressure from the burr protecting the membrane as soon as we grind the sinus bone. Using this innovative tool, only 3 seconds, we can get good access to the sinus membrane. And at this point, I did not know where the implant is above the membrane or below the membrane. But I would like to do sinus lift for this patient, and perhaps implants if I can, to minimize trauma to our patient. So I just pretended that implant is below the Schneiderian membrane, and I begin to lift and try to find the implant below the Schneiderian membrane. Unfortunately, I was not able to find the implant. It was not under the Schneiderian membrane. I looked everywhere, and I could not find the dental implant. So where could it be? Where's the implant? When I took another X-ray, it was moving around, which means it was outside of Schneiderian. So I have no choice but to perforate the membrane. I actually cut it with scissors so that I can have access inside the Schneiderian. Then, by using the gravity, I had the patient sit up, and gravity helped me to push the implant downwards. So as soon as she sat up, as you can see, I was able to see the implant, and I took out the implant. Now, we have huge perforation. Can I still graft bone graft for this patient? How can I patch this membrane? We can use collagen membrane. The problem is, if the collagen membrane goes into the sinus and it gets dislodged, it blocks the ostium, then we will have a huge problem with sinusitis. I do not want to take the risk. So what is the best way to seal torn Schneiderian membrane? The best way to fix soft or hard tissue is bone marrow aspiration. We can take bone marrow from many places, but least traumatic place to take bone marrow is tuberosity. Tuberosity, as we all know, is very soft bone. It's like sponge. So we're able to penetrate the tuberosity with 20 gauge needle. And by penetrating the tuberosity with 20 gauge needle, I am able to aspirate bone marrow, which has cells, which has the stem cells, growth factors. It has all the ingredients that I want to fix this torn membrane. So as you can see, very atraumatically, you can draw bone marrow from our patient. So we draw the bone marrow, and this is very different from PRF or PRP or PDGF or other different types of osteoinductive material. Why? Because this is very, very sticky. And my preliminary study shows that CD34 and 45 cells are present in great amount in this location. So we've been playing surgeries with osteoconductives for many years. Then we try to advance our science with osteoinductive. But in 2019, I think it's time to go into osteogenic and have the best material, which is the stem cell for our patient. Remember, this is a huge tear in Schneiderian membrane. Just by applying my bone marrow aspiration, after 20 minutes, the huge perforation is gone. And now I am able to add bone for this patient. We added additional PRF. And now, because the tear of Schneiderian membrane is gone, I am able to add bone for this patient. Bone marrow aspiration from tuberosity is very special because it clots so fast. It has so many osteoprogenitor cells. You will see in my presentation, the bone that I gain by mixing with this material is phenomenal. And the handling is really nice because the bone graft, they stick together. Some people call this sticky bone or steak bone. But whatever it is, it holds the bone graft together and you will have great result for our patients. So once again, we went to the other side as well. We removed the other implant from the other side. We applied the same technique. And after the CT scan, even though there was large perforation, you can appreciate that the bone grafts are held together. And this is a huge, huge secret in bone grafting technique. So I want to show you 5 hot tips in bone augmentation, and number 5 is bone marrow aspiration. Are you guys ready for number 4? Let's look at number 4. This young lady came to my practice, and she had a very limited income. She said, I need to extract 4 wisdom teeth, and I need to have 3 dental implants. Of course, here we have some vertical bone loss, some horizontal defect. Does dental implant last a lifetime? I don't think so. If it lasts 30 years, I think it'll be good. Also, is dental implant as good as our natural teeth? Unfortunately, answer is no. Developing nice emergence profile is the most difficult part. Most common problem I have in my practice is patients complain that food gets stuck under the haunting area because of improper emergence profile. So when a young patient comes to my practice, I don't want to do damage to our patients. So I think again, what is the best treatment for our patient? For a young lady like this, instead of placing 3 implants and wisdom tooth extraction, I like to do no implants and utilize orthodontics to close the gap. This is the best way to have the best emergence profile And economically, this is the best way for the patient as well. So please remember that orthodontics is very, very important. If you want to practice best implant dentistry, you cannot do it with orthodontic treatment. When you are missing a tooth, opposing tooth will erupt, and you need to utilize orthodontics to intrude the opposing teeth. If the distal tooth mesializes, you need to use orthodontics to distalize and recreate the lost space. We love doing surgery. In fact, I love doing surgery. We can do GBR technique, we can do bone block technique, we can do rigid splitting technique. They are all predictable. However, every time we build bone, the problem is that we lose keratinized tissue. And we have to do additional procedure to add keratinized tissue. In addition, patient will have pain and swelling. What is the best way to build bone horizontally? Answer is orthodontics. Do not extract hopeless teeth, build it, and utilize simple orthodontics to build the bone. At the same time, you can build gingiva. You can build keratinized tissue for our patient. This is the least invasive way to build bone, yet this patient didn't lose a single blood. So always think about building bone with orthodontics. This lady is 54 years old, and she lost so much bone in the anterior. It's mobile. Yet, if you look at her smile, recession is not there. But we know, as soon as we extract, what will happen? The bone will collapse because no longer held, the gum will collapse because no longer held by the teeth. And she's 54 years old, still not married. If you mess up, you have to marry the patient. So the best way to grow bone is to do simple orthodontics. You don't have to have very high degree to know how to do extrusion. You just need to know how to extrude 1 millimeter per month. And next month, I will add more composite to add 1 more millimeter per month, thereby erupting 1 millimeter per month, very slowly. If you do too fast, it's called extraction. There's 3 ways, there's 3 things you have to remember when you are doing extrusion. Number 1, don't extrude faster than 1 millimeter per month. Otherwise, you will end up with bone. Number 2, you must grind the lingual surface so that patients do not have hyperocclusion. Because if patient has traumatic occlusion, what will happen? You will lose the bone. What is number 3? Number 3 is most important. Number 3 is to collect monthly payment. Now, after extrusion, once again, this is the only technique that can build bone and the gum at the same time. And now I have so much bone when I'm placing implants, it was very, very easy to place the implant. And we have enough bone, and now we can refer to our prosthodontic colleague to restore the case. So number 4 secret in bone grafting is orthodontics for optimal replacement of missing teeth. Are you guys ready for number 3? Come on, say yes! Number 3, we briefly talked about sinuslift, and Dr. Valentieri did a great job talking about sinuslift complication, especially when it comes to the artery. This is why I like to do crestal approach, because the arteries are about 16.4 millimeter from the crest on average, and you can have some shooting blood during the surgery. So in order to avoid this type of complication, I recommend doing crestal approach for most part. But when do we do crestal approach? Well, my teachers taught me that when I have more than 5 millimeter bone, we do crestal approach. When I have less than 5 millimeter bone, we do lateral approach. This has been the standard for many, many years. However, back then, panoramic X-ray, which is a two-dimensional X-ray, was the standard of care. Now in 2019, ladies and gentlemen, we have three-dimensional cone beam CT scan. So we have to utilize three-dimensional guidelines when we are doing sinus lift. I love doing short implants, but I like to use short and wide diameter implants. I don't like short and narrow diameter because I think those can give you problems, especially when patient is brachyfacial, lack of canine guidance. When you get large lateral intrusive force, it could lead to failures. So I only utilize wide and short diameter implant when patients have wider than 12 millimeter of ridge. When patients have very low sinus, but yet very wide, usually oxyface, brachyfacial, low mandibular plane, Broxer, they have wide bone. When God is telling you, you have wide bone, you have to place wide implants. When patients comes to you with narrow bone, then you place narrow implants. So when patients have wide implant, there's no reason to do lateral window. We can make window through the crest because the bone is wide. Why not make window through the crest? Now, when patients have very thin ridge, then you can use osteotome or other type of sinus lift technique or lateral window technique that I have shown before. So in 2007, I developed this technique called crestal window technique. Especially in extraction site, you can utilize the instruments to make window through the crest and place implant at the same time. This is crestal approach, but it's not a blind technique. You can still see the membrane, and it's not a blind technique. But there's no morbidity to the patient because there's no bleeding from the artery, and there's no incision at all. How about lateral window? Doing lateral window could be time consuming. However, by utilizing instrument such as this, anybody can open lateral window within 3 seconds. How many people know how to open a can? Very easy. It takes you less than a second. By applying the same concept, we can use the trephine to weaken the bone. Then we can utilize the bottle opener to pop the sinus open. And it takes 3 seconds to predictably remove the sinus wall without tearing the membrane. But this was developed in 2008. Now in 2019, 11 years later, I am proud to announce the iPhone 10 of sinus lifting technique. What's the difference? With the iPhone 10, not only do we predictably go into the sinus, but we don't tear the membrane. We actually use the hydraulic pressure to lift the membrane at the same time. So the whole sinus procedure becomes very easy because we're now lifting the membrane at the same time. But it's very important that the water doesn't shoot directly above. It has to shoot sideways. Why? Because sinus is never flat. Even though it looks flat, it has a slope buckling. So as you can see, as soon as we penetrate the sinus floor, immediately the hydraulic pressure will lift the Schneiderian membrane. This is the easiest way to lift the sinus. Once again, flat sinus is easy because it's perpendicular to the burn. You can utilize even hammer to lift the sinus. But most difficult part is when you have inclined plane. More slope you have is more difficult. So here we are simulating inclined plane at 45 or more. And as you can see, even though we are directly touching the Schneiderian membrane, it doesn't tear the membrane. Why? Because the water is coming from the side. Once again, flat sinus is easy, but inclined plane is very difficult. So here we decided to push the limit and even lift more than 2 millimeters into the Schneiderian membrane. And as you can see, at 1000 RPM, the membrane is still intact because water is lifting at the same time, protecting the membrane. Then how do we inject bone? Easiest way to inject bone is to use putty bone from the syringe called Nova bone. This is the best material that I like to use inside the sinus. By utilizing Nova bone, we're able to lift the sinus and further protect the Schneiderian membrane. Sinus is very contained defect. Even if you don't put any bone, it will become bone. Just by having blood, it will become bone. So let me show you a clinical case. Once again, most difficult case is when you have slope. Here is almost 90 degrees. This is the most difficult case because it's at 90 degrees. Flat sinus is easy, but at an inclined plane is very, very difficult. So short video. Flat has to be done on palatal side, not on the crest, because in case you get perforation, we don't want to have oral-enteral communication. Very important to make palatal incision. Then we will use our burr and we will lift the sinus, make the patients breathe in and out to confirm that we don't have any perforation, and I will utilize FDBA to pack and condense into the sinus. Slow insertion is very, very important because if you insert the implant too fast, you will burst the membrane. So it's very important to do slow insertion of dental implant. I like to utilize implants with mounts because in the middle I can verify the angulation. If needed, I am able to change the angulation of the fixture. And I utilize the mount to gauge how deep I am inside the sinus. And even though this was at an angle, I am able to predictably lift the sinus without perforation. So once again, it's safe to go into the sinus as much as 2 millimeters with this drill. And patient is happy because patient has no pain. This is my daughter. And she said, I want to be able to do implants like you, Daddy. But for a 5 years old daughter, how can I explain how to do an implant or bone graft? Because more I study, it's more confusing, right? So I try to simplify the concept of bone regeneration. It's actually very simple. If you want to build bone, you only need to know two things. So I told my daughter Rebecca, you only need to know two things. One, bone graft must be stable. If it moves, it's not going to become bone. So there are many ways we can stabilize the bone. We can use block graft with the screws. We can use titanium mesh, titanium reinforced membrane. We can utilize various techniques to stabilize the bone, and that is very, very important. Second, we have to have primary closure to keep the bacteria out from our graft and also to have best blood supply. So as long as we can have two, we can have nice bone for our graft. At the same time, I do not want to have a lot of pain and swelling for our patients. So I want to take you a journey of how I learned how to do bone graft. I always thought that autogenous bone is the gold standard really quickly. I don't utilize bone block anymore because it's not necessary. This type of older technique is not necessary. It's traumatic to the patient, and the result is actually is not as good as the newer technique without autogenous bone block. So I think bone block technique is gone. I don't utilize in my practice anymore. When patients come in with very, very thin ridge, we have problem with bone block because we have limited source. We have limited quantity. So titanium reinforced membrane is the go-to technique for me because it's easy to use. I don't like to use tags. I don't like to use bone screw. I only like to use titanium reinforced membrane because it's stiff. It will stabilize my graft. And I don't have to use screws or tags. You just need to overgraft the site and utilize the titanium reinforced membrane. Once again, no screws, no tags. You just need to stabilize it with suture, with internal mattress suture. After 8 months, you will see that we have nice regeneration without any type of screws or tenting screws or tags. In the mandibular procedure is very similar. Only difference is that we have to do decortication because mandibular bone is very dense in nature. So we also did a mandibular case for her. We have to relax the tissue buccolingually, and decortication has been done, and we have to achieve primary closure, and that is very, very important. So here we have to be careful not to place any pressure on the mental nerve, but again, I will utilize titanium reinforced membrane because I need to have stiffness to recreate the lost buccal bone. Primary closure is very important, and when we go ahead and open 9 months later, you can see that by using osteoconductive method, we can augment the site without limit. I don't have to depend on autogenous bone. This was truly a breakthrough in my career because now I can truly place the implant where the prosthesis goes. However, I must tell you, this is still old technique. I don't use this technique often anymore. Can we place the implant at the same time? Many of clinicians here have shown that it's possible. In 2019, instead of placing implant at the bone level, we have to place implant where the CEJ of that implant should go and build the bone at the same time. And by utilizing the same technique that I've shown, without any tags or tenting screw, just by using sutures, we can grow bone vertically as well. But still, this is old technique. When patients have very thin bone, can we place implant at the same time? You have to do it with precautions, because when patients have very thin bone like this, especially maxilla, as you are placing implant, the bone can fracture and you can do a lot of damage to our patient. So instead of under drilling, it's very important to drill accurately with very little stability on the implant so that we don't induce fracture of residual bone. And I like to place implant as palatal as possible, making dehiscence on the palatal side and fenestration on the buccal aspect. Then I will utilize membrane. Remember, we have to have stable bone graft. It cannot be moving during the healing phase. So either we have to use block graft or we have to utilize titanium reinforced membrane. In this case, I chose to use collagen membrane, and by stabilizing the collagen membrane, we decided to use block bone. This is a special block bone that doesn't require tacking, doesn't require any bone screw. And really quickly, because I'm running out of time, we can stabilize with just sutures. So the second surgery becomes very, very easy, because the removal of the membrane, in this case, is not necessary. But if I have to remove any membrane, I don't have to remove any screws, and it becomes very, very easy for our patient. So once again, this is a great material to use, and as you can see, we can build bone at the same time as placing implants. But still, this is still iPhone 2 only. Are you guys ready for iPhone 10 of bone grafting? When patients have peri-implantitis, for example, this patient came in with severe peri-implantitis, are we able to rebuild bone around failing implants? As long as you remove all the soft tissue and infection, and as long as you can get primary closure and stabilize the bone, this is possible. As you can see, this is supra bony defect. There's no bone, mesial, distal, buccal, palatal. But by utilizing the same concept, by utilizing bone graft, over grafting it with titanium reinforced membrane and getting primary closure, we can see that we can build bone even around failing implants. Well, remember not to wear removable prostheses. If you put any pressure and if it moves during the healing phase, especially first 3 weeks, you will not have any bone. So very important that patients have fixed prosthesis. And after 3 months, we decided to open. We can appreciate that we build bone all the way to the top of the fixture, even around failing implants. So once again, ladies and gentlemen, as long as you stabilize the bone graft and retain primary closure, we can build bone for our patients. Well, my journey here is, as a clinician, I do not want to induce a lot of pain and swelling for my patients. So what is the iPhone 10 technique for bone grafting? This is not something new. In fact, it's been around since 1980s. But it has been underutilized. So we tunnel, we don't make any incision at the crest to preserve the blood supply. But we need to have the right material to prevent movement during healing phase. So my good friend of mine suggested that we start doing tunneling. And I want to give credit to my good friend, Dr. Simon John, for continuing research in this topic. And now we can make incision just at the mucogingival fold, and we just tunnel. This procedure is wonderful for you and the patient because patients will love it because there's no pain, and you will love it because it will only take 5 minutes of your time. There's minimal suture to be done, and it's very simple and easy procedure for your patient. However, you have to be careful. Patients will not want to pay you a lot of money if you only spend 5 minutes. So take a long time to do this procedure. So after we packed, it's very important that you overpacked, and it's very important that you use bone marrow aspiration. Why? Because bone marrow aspiration allows you to make very stable bone, even without titanium reinforced membrane. So we will give very simple sutures. The procedure is very clean and very easy for the patient. Two weeks later, patient will report minimal pain. Sometimes patients will report severe pain as well. It's probably because of contamination. Because it's closed technique, if you have a little bit of saliva into a tunnel, it's not very forgiving. Patient will have lots of inflammation, lots of swelling, and if the patient says this was very painful procedure, you will have 0 bone. But if patient comes back to you 2 weeks later and says, this was wonderful, I don't feel any pain, then you will have so much bone. 6 months later, you can feel the bone. And as you can see, this bone was done only by doing simple tunneling within 5 minutes. Look at the amount of bone that we can have through a very small incision. It almost looks like tumor. I get academic orgasm when I see this type of result. And this little bit of more bone that supports the buccal bone is the key for long-term success for your dental implant. This is truly the iPhone 10 of bone grafting procedure. Due to limited time, I will go to... So, number 3 is to use minimally invasive approach. Number 2 is to preserve what we have, and as we saw in many literature, it's very important to preserve keratinized tissue. So whenever you're making incision, make lingualized incision to preserve keratinized tissue as much as possible. We need to have minimum of 2 millimeters of keratinized tissue around our dental implants. And also, we need to have buccal bone. It's all about buccal bone. So we used to utilize atraumatic extraction. In 2019, I don't do atraumatic extraction anymore. I do partial extraction therapy. Instead of removing the whole tooth, we preserve the buccal half of the tooth, and by leaving the root, we are able to preserve the emergence profile and the buccal contour for the rest of patient's life without thinking about shrinkage. And I do the same for pontic area, and as you can see, we can preserve even the pontic area forever as long as the patient is alive. This patient will have nice buccal contour. Third, we have to learn how to preserve papilla. As long as the patient doesn't have a periodontal condition, I always utilize papilla sparing incision in the posterior region. Instead of making very simple incision, we have to make Mickey Mouse incision in order to redevelop into proximal tissue. This is a modified Palach technique to utilize and bulk up the interproximal tissue and or to preserve keratinized tissue to our patients. Fourth, we have to preserve the Schneiderian membrane because we want to augment the sinus in posterior maxilla, and by preserving the Schneiderian membrane, there is no limit as to how much we can lift without doing any lateral window procedure. Lastly, and most important, is to preserve blood supply. By preserving blood supply, we can have great outcome. So why make incision? You're cutting the blood supply. Always try to do minimally invasive tunneling technique. So number 2 secret was to preserve what we have. May I get some permission to finish number 1? Can I have some extra minute? So planning is very, very important. If you do poor planning, your implant will be misplaced, and when you misplace your implant, it will be very difficult to prosthetically finish the restoration. However, doing guided surgery on the second molar is almost impossible because not many people can open wide. So we have to have different method to do to position our dental implants. Therefore, I utilize the stopper as my guide. In this case, it's 10.5 millimeter in diameter, so that I always position my implant on the center of the crown. If you are doing multiple implants, I utilize the same concept. I just made a stopper that is exactly same as 7.5 for bicuspid and 10.5 for the molar side. It makes the implant treatment very, very easy.
Really useful. Makes placing implants pretty simple. Exceedingly simple.
But the name is 3-in-1 kit because not only does it help you to position your implant, but at the same time, it helps you to save time. Instead of using multiple drills, in 2019, consider using only one drill. Only one drill. Why is it possible? How come nobody thought about using one drill for any implant size? Because of heat. By having hollow space, our research shows that when you have a hollow space, it doesn't create as much heat. So 47 degrees Celsius, based upon rabbit model, probably in human, we have much more higher temperature. But in rabbit model, we know 47 degrees Celsius is the threshold, and our study shows that when you have a hollow drill, it doesn't burn the bone. There's a difference of 10 degrees Celsius when you use hollow drill. And also by using hollow drill, we're able to collect bone at the same time. So this completely changed the way I practice my implant dentistry, and this will really help your practice as well. Lastly, the guided surgery has really changed my life. Even my 4-year-old son can do implants now because of guided surgery. This special patient came to my practice. He turned 100 years old. So we were talking about whether we can place implants on geriatric patient, and this patient said, I am sick and tired of wearing denture. Yet nobody wants to do implants on him because everybody's so scared. So because of his age, we want to use minimally invasive. I want fast surgery. This patient doesn't have 6 months for the bone to heal. We need to give the final prosthesis in just 1 day. But in 2019, that is possible. With guided surgery, with computer-aided surgery, we can plan the procedure in the computer and predictably place the implant for this patient without any threat. So guided surgery has been done, and I developed, once again, hollow drill because I don't want to waste time on this patient using multiple drill. Today's guided surgery has a lot of problem because too many steps. It's confusing. But what if you only have one burr and one implant? It shouldn't take you much time for this patient.
Patient here. Patient is 100 years old. So we're going to break record today. We'll be placing 10 implants with immediate loading, so that patient can have a nice teeth to chew on this Thanksgiving. Guide is pretty stable and in the position that we want.
So one burr, one drill. We don't want to lay any flap. In 2019, if we're not practicing guided surgery, we're not practicing at the level of standard of care. Because even specialists, even myself, I do guided surgery. Because I know if I don't do guided surgery, it's not going to be as good as if I were to freehand. So I'm going to skip this because of limited time. We were able to place the abutment and the temporary on the same day, and patient was so happy. From start to finish, we finished in 46 minutes, and we have the Guinness Book of Record, oldest patient to receive full arch immediate loading. Patient was so happy, he was able to eat barbecue for the first time. But how often do we have bone? In my practice, almost always, it's either patients have money and no bone, or bone and no money. And I'm sure we have same problem here as well. But if patient has no bone, consider doing MIT bone grafting technique, which only takes 5 minutes of your time. MIT technique has really changed the way I do bone graft for my patients. If you want to learn a little bit more about MIT technique, when you go to my website, you'll find a lot of hands-on courses on MIT bone grafting technique. So my last secret in bone grafting procedure is to utilize the latest technique and tools that we have in our practice. Thank you very much.
So now it's quiz time. Who can remember all the 5 techniques? So, any questions? I don't see any hands. Yes.
Tell me please, can I buy your devices in Ukraine?
Paul, are you here? Paul? In the back? You can talk to Paul. He will help you.
Okay, thank you. Second question. What dental graft material are used in your practice?
Very good question. I forgot to touch on that. And this is controversial, but I'm telling you from my experience. When I utilize DFDBA, the result that I get is not as good. A lot of shrinkage, and I have to wait a long time. So I switched to FDBA, which is mineralized. And then we have an option, cortical cancellous, or cortical only. In my hands, best material is cortical only. If you use cortical cancellous, it may work, it may not work. What I'm talking about is tunneling technique. When you do tunneling technique, you need stability of the graft. But when you use cancellous or DFDBA, it's too bumpy, it moves too much. However, by utilizing only cortical powder, the graft, after the tunnel, it doesn't move at all. And I think that is the secret. Stabilizing the graft with the right choice of a graft material. Very good question.
Questions? Yes. Question here.
одной из своих работ вы удаляли через полость рта имплантат, который был...
So that you can repeat.
Который был в гайморовой пазухе.
Can't hear you.
Let's get the question, please.
Скажите, пожалуйста, а не проще ли было отправить вашего пациента к лор-врачу? И тогда не надо было все это.
Very good question.
Спасибо. Thank you, Ashanti.
I am a periodontal specialist, and almost every month I have a case referred to my clinic to remove the implant. So since patient was referred to me, and I feel comfortable doing it with minimal hole on the bone, I choose to remove myself. But I agree, we may have option to remove it to ENT, but I believe my technique is less invasive because it could be done under local anesthesia.
Добрий день, мене звати Ігор. Таке питання. При тунельній техніці, як ви робите декортикацію? Яка саме методика? Чи то перфорація, чи то скріпками?
Very good question. You can utilize both scraping or with the burr. If you have time for next 3 days, we will be treating your soldiers. If you come to Marrow's clinic, you will be able to see the tunneling technique that we do for your heroes. We can make a tunnel and we can detach all the flap. We can even place the implant and then pack bone. So making decortication through a tunnel is not a hard thing. I invite anyone to come to Marrow's clinic if you want to see our action.
Дякую. І ще одне питання, якщо можна. Якщо по КТ я оприділив, що товщина кортикальної пластинки біля 3 мм, на яку глибину мені треба декортикацію зробити?
Very good question. You have to make decortication to the bone marrow for 2 reasons. To increase blood flow, and also it's a mechanical retention for your protein bonding.
A question while you're waiting. Sam, how much bone marrow aspiration in terms of volume do you use safely?
Very good question. It depends on the size of tuberosity. Some people have large tuberosity. I can extract as much as 10 cc. But some people have no tuberosity, like they have wisdom teeth, then I have limitation. Minimum I need. It depends on the bone volume. For 1 cc, I would need at least 1 cc to hydrate the graft.
One question.
Скажіть, будь ласка, під час операції з шаблоном і не використовуючи локотом, а використовуючи тільки одне єдине сверло, чи є ризик попадання в кісткове ложе для імплантанту залишків слизової оболонки і епітелію?
That's a very good question. Actually, I skip a lot. Remember, one thing we have to preserve is the keratinized tissue. So I make incision with number 11 blade, so that when I am drilling, the gingiva opens.
Дякую.
So we're getting the last question right now because we're really running out of time. This is the last question. The rest of the questions will be asked afterwards to Sam.
Вы когда помещаете постматологический материал в гайморовую пазуху, чем вы изолируете его от микрофлоры патогенной гайморовой пазухи? Там же мембраны Шнейдера нету.
Very good question. What type of bacteria do we have in the sinus? In healthy sinus, there is no bacteria. It's a sterile environment. So as long as the Schneiderian membrane is thin, and as long as the ostium is open, you can assume that there is no bacteria.
Thank you very much, Sam. So big applause, please. Thank you.
thoughts about lecture of samuellee. So it was absolutely incredible, the information, the structure of the lecture, his speech. We hear a lot about new methods, and it's really new for Ukraine. Also, he answered all our questions, and we get all the information that we need. So thank you, Samuel.